I want to thank the organizers and specifically Dr. Adriana Farhado for giving me the opportunity to participate in this wonderful symposium. I was listening to other talks. I think I've learned some Spanish all along. So I'm going to talk today about disorders of neurotransmitter metabolism, and specifically I'll talk about aromatic amino acid decarboxylase deficiency. This is a disorder of neurotransmitter metabolism that is, while it's rare, it's more common than other ones. It's well described, and also it may serve as an illustration to a gene therapy. And we heard such wonderful talks today about different ways of different methods of gene therapy, and this condition will be illustration of one of them. So these are my disclosures. So this is an outline of my talk. I'll talk about neurotransmitter synthetic pathway, about effects of aromatic amino acid decarboxylase deficiency, which I will call from now on Aadc, effects of deficiency of this enzyme on dopamine, serotonin, and their metabolites, and also about clinical features of Aadc deficiency. I'll talk a little bit about medical treatments, but of course, we are interested in gene therapy for this neurometabolic condition. And as I said, this condition is now being treated by gene therapy. So what are neurotransmitters? These are chemicals that allow to transmit information from one neuron to another, and there are hundreds of different neurotransmitters, and we are going to talk today about this group. They are called monoamines, catecholamines, indolamines, and you all know that neurotransmitters are stored in vesicles in the presynaptic membrane, and then electrical stimulus is needed for these neurotransmitters to come into the synaptic cleft, and then the axonal terminal takes these neurotransmitters, and that's how information is being transduced. I just want to show you how sort of simple the molecules of these neurotransmitters are, but how important is their role in our behaviors and our well-being. Like dopamine is in charge, is needed for executive function, for motor control, for emotions, for reward, and norepinephrine, which is a metabolite of dopamine, and epinephrine, metabolite of norepinephrine. They are, of course, necessary for maintaining blood pressure and heart rate and body temperature. And they're also needed for attention and focus and stress. And we all know that serotonin, how important it is for our behaviors, for mood regulation, for appetite, etc. So this is the pathway, synthetic pathway of these neurotransmitters. As you see, L-DOPA is converted to dopamine by this enzyme, Aadc, and 5-hydroxytryptophan is converted to serotonin by the same enzyme, and vitamin B6 is a cofactor of this enzyme. So what happens if this enzyme is deficient? Patients with Aadc deficiency have low dopamine levels and low metabolite that can be measured in the spinal fluid. They have low norepinephrine levels, low epinephrine levels. They also have low serotonin and low melatonin levels. So this is what happens when there's just one enzyme is deficient. Aadc deficiency was described in 1990 by Kip Hyland, who still runs the lab in Atlanta, Georgia, and still very active. And that's where we send our samples of CSF and blood if we suspect disorder of neurotransmitter metabolism. And since then, there were about 120 patients reported worldwide. But this is a total underreporting, if you wish, because, for example, you don't see patients reported from Saudi Arabia, but we do have patients from Saudi Arabia who are followed in our institution. And I'm sure that there are patients in Colombia. Maybe this map is a bit outdated, but these patients can be found worldwide. There are some areas some countries in the world where this condition is more prevalent. It's mostly in Taiwan and in China because there is a found mutation over there. So a lot of research on this condition and gene therapy comes from Taiwan. So there were several studies trying to estimate what are the birth rates of this condition. So they were done based on pilot studies of whole exome sequencing in neonates or newborns, or in measurement of dopamine metabolites in the same population. And this is an estimate for the United States. This is for European Union. This one for Japan. So the prevalence estimate of this condition worldwide is 1,800, and as you saw, only about 120 reports were made so far. And the mean age of symptom onset is 2-3 months. So these patients present very, very early, but they are not diagnosed up until they turn 3.5 years. Some, of course, are not diagnosed at all for different reasons, and some receive diagnosis much, much later. This is a Aadc protein. It consists of 2 identical subunits. And this enzyme converts, as we already talked, L-DOPA to dopamine, and several examples of mutation is shown. As I said, there is a found mutation in Taiwan which produces quite severe disease. But other than that, there are no definite genotype-phenotype correlations found. So patients with Aedc deficiency, as I said, they present very early, sometimes in the newborn period, with temperature instability, with blood pressure instability, but the majority of them present at several months of age. And this just illustrates to you what a normal child is supposed to do, and the milestones for normal child. So patients with Aadc deficiency, the majority of them, they don't reach any milestones. They don't have head control. They don't sit, stand, walk. So this is a very, very severe disease. And this is a very simplified version of what I already had shown to you. So Aadc deficiency causes deficiency of all these catecholamines and monoamines. So what happens if dopamine is deficient? Obviously, dopamine is needed for normal motor movement. And so these children develop dystonia, rigidity, hyperkinesia, tremor, Parkinsonism. And let me try to show you what happens. So this is one of our patients, actually from Saudi Arabia, and all families gave permission to demonstrate this video to you. So you can see this child is not moving very much. He just stares into space, and he also looks up. And this is one of this ocular gyrate crisis. I will show you another video demonstrating this ocular gyrate crisis. So again, dopamine deficiency produce these ocular gyrate crises that are eye movements, conjugate eye movement. Children usually have their eyes deviated to one side, frequently upward, and this is a spasm. These ocular gyrate crises are due to spasm of ocular muscles, and this is a sort of a hallmark of this disease. Some other disorders of neurotransmitter metabolism, although not all of them, may produce ocular gyrate crisis, but if you ever see a patient who has this crisis, and this episode, they last for hours, 5, 6, 7, 8 hours sometimes, and they are also accompanied by dystonic crisis. And so please evaluate these patients for Aedc deficiency. So this is another patient of ours, and she also, has this ocular gyrate crisis. You see her eyes are deviated, and she has dystonic posturing at the same time, and this is very difficult for families to watch child going through that, and especially difficult when families do not have definitive diagnosis for their child. So now dopamine is converted to norepinephrine, and deficiencies of these catecholamines, of course, they produce arterial hypertension, bradycardia, temperature instability, especially hypothermia, as I said, seen sometimes in really the neonatal period. And because of the relative cholinergic axis compared to deficient norepinephrine and epinephrine levels, this patient have ptosis, and sometimes it's severe, and they have excessive sweating and nasal congestion. And serotonin deficiency and melatonin deficiency produce mood instability. These children are very irritable. They also have sleep problems due to serotonin and melatonin deficiencies. So I just want to illustrate what I'm talking about with several examples of our patients. So one is now 25 years old. It's a young man who first came to us when he was 3 months old. He had no head control. He had difficulty feeding. At 4 months of age, he developed stiffness, mostly at night, as many of these conditions, when there is dopamine deficiency, initially, especially, they can present with movement problems more so at nighttime. And then at 6 months, he developed ocular gyrate crisis and prolonged episodes of severe dystonia. And of course, what we neurologists do, we do brain MRIs, but his MRI was unremarkable. And his EEG was not normal, but it was not consistent with epilepsy, because if you do EEG during one of these ocular gyrate crises, which are commonly mistaken for seizures, the EEG would not confirm that that's epilepsy. So he received diagnosis of cerebral palsy, but astute clinicians did diagnostic workup, and he was found to have Aedc deficiency in the CSF. So you see, that's been a while ago, and we still follow him, and this is him. And you can see that he is quite hypertonic. He may have some difficulty with head control, and he has ptosis, but he's not the most severe case of what we had. So he is on a very complicated medication regimen. This is him too, and he likes to watch baseball games, and these videos his parents are asking him about Red Sox. But again, you can see that he has difficulty with head control and overall is not very functional. And then there was another patient who came to us at the age of 17, but his story was very similar. He developed these episodes of dystonia, oculogyric crisis at age 6 months. He was diagnosed with cerebral palsy, and then he was treated for some reason with Haldol, which of course made him much worse. And then he unfortunately passed away at the age of 23 years because he was pretty much untreated his entire life. And then the last patient is a 24-year-old young woman, and her symptoms started right after birth. She is a severe case, and she had hypertonia, dystonia, oculogyric crisis. Her MRI was normal at that time, as it is for these patients. And this is her. This is her when she was a bit younger. Again, you can see her eyes are deviated. She has hypertonia in her trunk and dystonia in her arms and legs, and some probably dystonia in her facial muscles too. And this is her now, and you can see she has trach, and this is again, this is a dystonic spasm, a dystonic crisis, and this crisis lasts for hours and hours, and see her eyes are deviated, oculogyric crisis. She has trach not because aromatic amino acid decarboxylase deficiency affects lungs, but these children may develop severe scoliosis and develop restrictive lung disease. And of course, they also have a lot of other problems. They are not able to feed, they're G or J2 dependent, and that's her x-ray, which necessitated her having trach. Now, we recently repeated MRI on her, and as you can see, it's not entirely normal, but it's this totally non-specific. You would not be able to make any definitive diagnosis based on this MRI. So these patients are very frequently diagnosed with cerebral palsy. And of course, now the whole concept of cerebral palsy have been reviewed and renewed. In the past, we always felt, well, you need to have problems at birth and the delivery, and evidence for brain damage on the MRI, typical for children with cerebral palsies, with hypoxia, ischemia at birth. Now the concept had changed a little bit because now there is a recommendation to do genetic testing in cases of cerebral palsy, especially when there is sort of no clear-cut indication of something happening prenatally or during the delivery, because it was found that many cases of cerebral palsy have genetic basis. But these children who were diagnosed in the past, children with Aedc deficiency, they were diagnosed with cerebral palsy, and that was it. They were not investigated further. They did not have testing on spinal fluid. They did not have testing on CSF. They just carried diagnosis of cerebral palsy, and that was, of course, a disadvantage to them. Some patients were diagnosed with mitochondrial disorders because dysautonomia may be seen in mitochondrial disorders, and this patient with Aedc deficiency, they also have temperature and blood pressure instability. Very commonly, these children receive diagnosis of epilepsy because oculogyric crisis may remind seizures. Some were diagnosed with genetic dystonias and even with disorders of glucose metabolism because of low catecholamine levels. They may have low blood glucose levels. So there is a great summary, a consensus guideline for the diagnosis and treatment of Aadc deficiency. But as you can see, it's from 2017. It's not that much change since then, but in many ways, genetic testing had become more available, because this consensus recommends that 2 out of 3 diagnostic tests would be positive to arrive to the diagnosis of Aedc deficiency. So these patients usually have low levels of serotonin and dopamine metabolites, high level of dopa metabolite, 3-O-methyl-dopa, and normal pterins. They may have low levels of Aedc enzyme on plasma, and they are found to have mutation in DDC gene. But I don't know how about Colombia and South America. In the United States, it became more sort of simple to get whole exome sequencing. Many children are diagnosed this way. So that's the one of the ways to find the mutation and then confirm it either by low level of enzyme or by testing spinal fluid. Also, there is a lab in Vita that offers panels which include DDC gene, so gene for Aedc deficiency, several panels which are very broad, and these panels are free of charge. So if you have a patient and you suspect this patient may have disorder of neurotransmitter metabolism or Aedc deficiency, you can send DNA to this lab, and and testing will be done for free. Another relatively easy, well, actually quite simple way to diagnose this condition, or at least to suspect it, is to do testing on the blood, even on the filter paper, on the dry spot, for this 3-O-methyl-dopa, which is a metabolite of L-dopa. So if L-dopa is not converted appropriately to dopamine, this metabolite level goes up in blood and in CSF, and you can test for that. And this is done by the lab of Keith Hyland in Atlanta. And if you're interested, I'm sure he can send you the kits for that. So, treatment for Aedc deficiency. So for many years, it was just medication management, and patients with this condition, they cannot receive dopamine, does not cross blood-brain barrier. But if you give them L-dopa in the form of Cinemet, they're not able to convert it to dopamine because enzyme is deficient. So they were mostly treated by dopamine agonists, such as pergolide, pramipexole, Requip, retigatin, with some success. Some patients reported that their ocular gyro crises perhaps subsided and were not as frequent. These patients were also treated by MAO inhibitors. MAO, destroys serotonin and dopamine, and also by B5P or by vitamin B6, because it's a cofactor of this enzyme. But there were really no great success stories. Most patients continued to suffer these severe symptoms over the years. There was some symptomatic therapy tried, but really nothing worked very well for them. And many patients had significant side effects from this medication, and some of them ended up on numerous medications. Their schedule is horrific. Like they get this dopamine agonist like every few hours, day and night. And of course, this is extremely exhausting for them and for the families. And so gene therapy came along, and as I said, the condition is prevalent in Taiwan, China, and so that's where this gene therapy came from. There were several trials done, and in Taiwan, and one trial in Japan. And as you can see, many patients were already treated, and some of them been watched for already 9 years. One of them, the patient enrolled in the trial. So that's a very long follow-up. So what is done is that AAV2 virus is injected directly in the putamen. This virus is loaded with a normal copy of DDC gene. It's done with stereotactic surgery, and it's done on both sides, but just once. And this therapy proved to be a success. There were no significant side effects except for pyrexia in some children and dyskinesias, which could be expected after such therapy. And almost all children demonstrated gains in their motor function and became more emotionally stable. And the increase in the dopamine and serotonin levels in the brain were proven by PET scans and also by measurement of dopamine and serotonin metabolites in the CSF. So, of course, children were evaluated on different scales for their motor development and so on, but I just want to show you a couple of videos of what this gene therapy had done to these children. So bear with me. So as you can see, this child is severely affected, no head control whatsoever, and severely hypertonic. And this is how he looks after gene therapy. And you would not expect a child with this severe form of Aedc deficiency to be able to do this ever without gene therapy. So there were cases of Aedc deficiency that were mildly treated with gene therapy, and some of these children started to walk independently. And another video and another child was also severely affected. So this is how he looks, almost 3 years old. Quite impressive too. All right, I think you get a picture. So in conclusion, I just want to say that Aedc deficiency is a debilitating condition, and it is very frequently unrecognized and misdiagnosed. Aedc deficiency should be on the clinician's radar when patients present with early onset dystonia and, of course, ocular gyrate crisis and other symptoms that were discussed in this talk. And making a diagnosis of Aedc deficiency is extremely important and is not that complicated if you really keep it in mind. And gene therapy is safe and may totally change disease trajectory. So while all these trials that I described, they were done in Taiwan and in Japan, but this gene therapy is now coming to the United States and other countries. And so we really hope that these children will be helped and if not cured, but their lives will be impacted in a very beneficial way.